What's up, guys? Welcome back to another Clinical Conversations video. If you're new here, my name is Dr. Brian Larish, and I'm the owner of a cash-based physical therapy clinic, as well as the creator of the PT Growth Academy. In this video, we are discussing biomechanics of the pelvis. Now, you might be asking yourself, is this really something that I talk about with my patients? Yeah, I do. I actually talk about it a lot with them. Now, I put it in terms that they'll understand, and I use a model, which is super helpful. But what you'll find is that when you start going into some of these movements of the pelvis, the patient really appreciates it. They actually start to understand what's going on and what's limiting them from an injury standpoint or limiting their overall movement. Now, when I say biomechanics, I want to talk about the practical side. I feel like a lot of us in the industry just know information, but there's no application to it or linkage as to how that knowledge actually applies in the real world. So we're going to quickly talk about squatting and deadlifting. This could go on and on and on and on. This is going to be a very brief synopsis. If you really want to dive deeper, I would encourage you to check out the Clinical Coaching Specialist certification. I will leave that in the link below so you can learn more. So we have a pelvis here, and let's talk biomechanics of deadlifting and then biomechanics of squatting. So when it comes to a deadlift, ultimately, someone that is going to be better at deadlifting is going to have a slight anterior center of mass. This anterior center of mass comes with internal rotation, adduction and extension of the innominate bones, and nutation of the sacrum. Now, this is the part I'm talking about. That's great to know, but what do we do with that information? How does that actually help us out in the clinic? Or if you are a patient watching this, how does this help us out? Well, it really comes back down to this posterior outlet back here, and the space where my fingers are. So we have a lot of muscles here, a lot of external rotators, glutes, piriformis, and when we're internally rotated, we actually expand and open this space compared to the front. And what this means is we have the ability to move into it. When we have an area that's more expanded or muscles that are eccentrically lengthened, we then can move through or into that motion. I think of it as an unlocked door. You can walk through an unlocked door, but you can't walk through a locked door. So internal rotation allows us to horizontally move this way, and we get that horizontal motion because a byproduct of internally rotating is compression in the front. So think of like our front hip, a lot of hip impingement type scenarios. And we just don't have enough space here. So when someone tries to squat or move vertical during a deadlift, they're blocked. They don't have that space. And so I think that's really useful to know and understand and visualize because it helps you understand the patterns of your patient. And the next thing I would say is force production. When we internally rotate, the pelvis goes inwards. That inwards position is going to help the femur move in and help the foot find pronation. When we deadlift, it's a requirement to push into the ground. And we ideally want to do it in the right way. And a lot of people don't, but that's for another video. But the only way we're going to have a shot at doing it the right way is if we can get internal rotation of the pelvis. That's going to bring us to the floor so we can actually put force into the floor to press into it to stand. So biomechanics, position, anterior opening back here allows us to move into it. Secondly, it allows us to put force down into the ground. So that's an easy education piece that you can use with your patients, and they'll really start to understand and probably say like, oh yeah, I feel that. It's hard for me to find the ground. It's not hard. And it's just a great way to provide even more value to patients. On the other hand, we have squats, and it's just the opposite. So if you're learning this, learn one, and then it's just the opposite for the other. And you can start to fit the missing pieces as you go. So a squat is going to be a pelvis that is a little bit more posterior, a little bit more vertical, upright, however you want to think about it, compared to this anterior center of mass. And we're going to have external rotation, abduction and flexion of the innominate bones, and counter nutation of the sacrum. Again, what does that actually mean? There's no way it's going to be valuable just to know that in the clinic. We need to actually apply it. External rotation is going to close down the gap. And I will say that I'm moving through these in a greater range of motion than they actually do. This is a plastic pelvis model. It's just to help us visualize it. So external rotation locks the door, closes this down, and as a result, we open in the front. That is going to help us stay vertical. Think of it. If there was a door back here, and you tried to push into it, but it was locked, you're just going to slide vertically down. The same thing happens with the pelvis. On the force production side, external rotation is going to drive down the femur into the foot into more of a supinated position. So it's a little bit harder to produce a ton of force, but it's a lot easier to find and create space. External rotation is really going to help us move into spaces. So during a squat, we still need to pronate. We still have an internal rotation component, but from a biomechanics perspective, someone that has an easier time squatting is going to probably be a little bit more posterior, externally rotated, and not the best at producing force, but probably more on the flexible side and able to move in and out of space. So that's a general idea of how I like to use the pelvis and show patients, hey, this is where your problem is because this is expanded or this is compressed. We need to actually work the opposite so we can get you rotating or squatting or deadlifting, whatever the scenario is. But if you don't have a model, I would definitely encourage you to grab one. Use this in the clinic. It makes your life a lot easier. It helps your patients out. And it's just a way that elevates and raises your standards as a clinician. So I hope you found that valuable. I will see you guys in the next Clinical Conversations video.